I welcome Mr. Abdul Ghani Ibrahim, Abidang Aloti, Abhijit Chattopadhyay, Abraham Ayuba Kabini, Abubakar Haruna, Clark Hanzara. Again, I beg your pardon if I mispronounce your names. Uh, I try to pronounce uh, as precise as possible. If I mispronounce, again I beg your pardon. Then so we have got 25 attendees so far. So this is going to be one of the, I believe it's going to be a most important knowledge sharing webinar. The most important and one of the oldest bacterial disease which is listed by OIV and infectious and contagious disease. The topic is going to be presented by eminent academician, Professor Dr. Dan Birney. So to introduce Dr. Professor Dan Birney, he's an academician, he's a professor. Professor Dr. Dan Birney is a distinguished professor of infectious diseases and large animal consultant with over 20 years of experience in large animal ambulatory practitioner also. Currently, he serves as a lecturer in Department of Veterinary Medicine in Ahmadu Bello University, Zaria, Nigeria. Currently, Dr. Professor is a fellow and resource person at the College of Veterinary Surgeons of Nigeria, specializing in large animal infectious disease. Throughout his career, he has guided both undergraduate and postgraduate students on farm visits, covering both pastoral and sedentary herds. And also, Doctor has conducted extensive research and has published enormous number of studies in local and international journals focusing on large animal, particularly pastoral and sedentary cattle herds. So this disease is also one of the important diseases in uh, pastoral herds. So I take immense pleasure in welcoming Dr. Professor Dan Birney to have this lecture, to have this webinar be presented. So over to you, Dr. Professor. So please go ahead and present this informative webinar on contagious bovine pleuropneumonia. Over to you, Doctor.
Okay, hi everyone. As earlier been introduced, my name is Professor S. Dambrini from the Department of Veterinary Medicine, Ahmadu Bello University, Zaria, in Nigeria, West Africa. Thank you for this opportunity where we come to share knowledge concerning one of the deadly diseases that is affecting the livestock industry, which is contagious bovine pleuropneumonia, also known as long plague. And in the local community, it is also called Chiwon Huhu in Nigeria. It is an infectious and contagious respiratory disease of cattle caused by Mycoplasma mycoides subspecies mycoides. It is characterized by a marked edema and proliferation of interstitial tissues in the lungs, diffuse pneumonia, and seroprevenous pleuritis. The Mycoplasma small colony is the one responsible for the disease outbreaks in cattle. It is anaerobic and non-motile. Although it lacks cell wall, but it stains well with Giemsa positively. By way of history, this disease was introduced into sub-African continent in sub-Saharan Africa around 1800. And it entered South Africa from Holland in 1884 as reported, where about 100,000 animals die within 2 years of the disease outbreak. And from South Africa, due to cattle movement along borders of neighboring countries, outbreaks were reported. in places like Namibia, Zimbabwe, Botswana, and other neighboring countries. It is one of the, or
Sorry
it
to
is
interrupt you,
a
doctor.
bacterial disease.
Professor,
No?
could you just keep changing the
Am
slides?
I audible?
Yes, we are. Yeah, we could hear you, but if you can just change the slides when you are presenting the webinar, we wouldn't be able to see the slides changing. It is still in the front.
You are not seeing the slide?
No, we are seeing only the first slide, which is being
Hello?
presented. So,
All right. Next slide. Yeah. So, as I was saying initially, the next slide, I've explained this slide. All right, I was talking about the history of the disease, how it entered Africa and later started spreading gradually, causing outbreaks. And as at 2013, a country like Gambia ended up in eradicating the disease. But in 2013, the disease was reported to have resurfaced after 45 years of eradicating the disease. And in Eastern Europe and Asia, particularly the Middle East, there has been some pockets of outbreaks. Next slide. Yeah, these are some of the African countries as at 2014 that have reported the disease. But from 2014 to date, the concerted effort to eradicate the disease did not yield much fruit that is expected. And therefore, the disease remained endemic in so many of our countries. And the map of Africa here is indicating the countries that were affected as of 2014 that reported the disease. But today, more countries have reported more than what is represented on the map. And the other map on the other side is indicating some of the risk areas that the disease is so much endemic. Next slide. Next slide.
economic impact of the
Next slide. Next slide. Next slide.
is it the one you wanted?
Next slide.
Is this the one, Professor, you want? Direct loss and indirect loss. Economic impacts. Could you hear us, Professor? Um, we apologize. It seems to be having some network glitch with Professor's locality. There's some network error, it seems. So we'll try to see for another couple of minutes if Professor would be able to join us and continuing presenting this webinar. If at all, if he couldn't able to join, then we try to take it over from here, and we ourselves will try to finish this webinar. So let's wait for a couple more minutes, and I apologize for that. So I think Professor has joined again. Good. Professor, is this the slide you wanted to be presenting now? Would you able to hear us, Professor? Professor, would you able to
Hello?
hear us?
Hello?
Could you hear us?
Hello?
Yeah. Yes, Professor, go ahead. Is this the slide you wanted to present now? From here, we are moving to this slide now. Professor,
Hello?
yes, we could hear
Hello?
you. We could hear you. Could you able to hear us? Please keep presenting.
Hello?
Yes, Professor, we could able to hear you. Please continue presenting this webinar.
Hello?
Yes,
Hello?
Professor, we could hear you.
Sir, can you hear me?
Yes,
Yes,
yes.
we
Can
could
you?
hear you. Dr. Ayuba, could you please coordinate with the professor? Just ask him to continue. We could hear him. Dr. Ayuba?
Yes, I'm calling him.
Yeah, please. Something up.
Again, I apologize, every participant. There seems to be a network glitch with in professor's locality. We are trying to sort it out to our best. So I
Okay.
request everyone to bear with us for another couple of minutes
Okay.
to see if professor could be able to resume his presentation.
Yes.
Professor, would you able to hear us now?
Hello?
Yes.
Yes, we can hear you, sir.
You can hear me, right?
Yes, yes, yes. So is
Okay,
this the
next.
slide you wanting to
Okay,
present now, Doctor?
next slide.
Economic impacts, right?
Next slide.
Is this the one?
Next.
Economic impacts. Is this the slide you wanted to present, Professor, now?
Next slide.
So this is the distribution map we are now. So then the next
Yes,
slide is
next slide.
next slide is
Next slide.
economic impact.
Yeah, it's okay. Yeah. Yeah, the economic impacts of the disease is so enormous. An estimated annual loss at some African countries was around 2 billion US dollars. And the losses as at 2016 and 6 due to this disease in about 12 sub-Saharan African countries was estimated to be 30 million euros. The total economic cost per country was estimated to be 3.7 million euros per country in Africa. In Nigeria alone, as at 1996, it was estimated to be $1.5 million. One state alone in the north central Nigeria was 294,800,000 US dollars. But this is as at 1996. From 1996 to now, the disease has been on rampage, and therefore the economic losses is more than what is now being presented. And therefore, the calculation of the economic cost in terms of currency. Next slide. Next slide.
Yes.
In terms of currency, the estimated cost in terms of currency, in terms of euro, dollar, or the local currency, was estimated as a result of the direct losses due to this devastating disease. For instance, the cost of treatment, cost of vaccination, cost of surveillance and research, including quarantine, etc., reduced milk yield, and the death of the animals when outbreaks occurs, all cumulatively amount into billions of US dollars when quantified. But there are certain indirect losses that is difficult to quantify in terms of dollars or euro or local currency. For instance, whenever there is an outbreak of the disease, of course, marketing of such animals is being delayed until they recover and the body condition improves. That way, the marketing has been delayed. And loss of weight and ability to work as a draught animals, particularly bulls that are used in regional farmlands, are also affected. Loss of trading permits, particularly international trade. Whenever there is an outbreak, unless the disease is being eradicated, many countries may not want may not import such product from you, whether live animal or animal product. Another thing that is also that is classified as an indirect loss was the stigmatization of that particular herd that is affected by other herdsmen. Here in Nigeria, whenever there's an outbreak in a particular herd, the neighboring herds tend to run away from this particular herd, and that stigma remains. Even that particular herd has recovered from the disease, people will run away from such an individual. That alone causes psychological trauma to the herd owner. Aside from this, cattle is regarded as a wealth. It has a way of enhancing the social status of the owner within the community. The more the population of cattle you have, the more you are being highly regarded in the society. And where this particular disease or any disease outbreak reduces the population of this animal from that individual farmer, he begins to lose his social status as an important influential person in the community. Such alone is so devastating psychologically to the owner. So the effect or the economic impact of this disease cannot only be quantified in terms of euro, dollar, or any local currency. The psychological effect, the trauma it causes to the owner also needs to be taken into consideration whenever we are looking for solution to eradicate or control the disease. The psychology of the farmer and their prestige cannot be pushed aside. That is also very important. Next slide. In terms of morbidity, can reach up to 100% in susceptible herds, depending on certain factors. For instance, those herds that are kept in confinement, the disease then to ravage them because of close contact. And also, if there are concurrent infection and starvation, these ones tend to increase mortality. And the mortality can range from 10 to 80%. And about 25% of those animals that may recover from the disease tend to become carriers. Most of the time, they look apparently healthy and therefore serving as a focal point for the infection. Next slide. Transmission is by direct contact through inhalation of aerosolized infected droplets. And there are risk factors that are encouraging transmission. Like earlier pointed out, management practices such as keeping cattle together in small herds at night, sometimes in fear of thieves and predators. So that tends to also enhance transmission because of close contact. Mixing of herds and local distance trekking of cattle along stock routes and at communal watering points also enhances the transmission because of close contact too. Dust generated by mass movement of cattle, particularly during dry season. In West Africa, we call such kind of season like during Harmattan, where you have windy weather, dusty weather, and dry weather. The pathogen tend to spread easily during those periods. And the nomadic culture and transhumance practices, whereby you can see different herds converging on a particular pastoral land. They graze together as in terms of communal grazing areas. This one also, these practices enhances the transmission of the disease. The incubation period can range from 3 to 6 weeks, and sometimes up to 6 months. And the course of the disease can be 5 days in acute. It can be less in terms of per acute, and it can be weeks when it is becoming chronic. Next slide. There are certain chemical substances, including enzymes and sugars, that play a part in the pathogenesis of the disease. Such include peroxide and superoxide that disrupt the host integrity. Phospholipases reduces surface tension of the alveoli surfactant, collapsing the alveoli. And the galactan polymer modulates the immune response and promotes the dissemination of the organism. Next slide. Such that you see cascades of events ranging from adhesion, colonization, high inflammatory reactions, septicemia. All of these cascade of events culminate in the high outpouring of plasma and fibrin, giving these marbling effects. Next slide. And the inflammatory processes that takes place affect the bronchos, leading to bronchitis, bronchochialitis, alveolitis, unilateral pulmonary necrosis as a result of pulmonary thrombosis of vessels, marked serosanguinous fluid accumulation in the interstitia and pleura, and sometimes sequestration, particularly when it is becoming chronic. Pulmonary vessel thrombosis developed before the pneumonia lesions, and about 50% of the cattle may not clinically be affected in the face of outbreak, even though infection has occurred. This is dependent on the body condition of the animals and the season. If it is during dry season when pastures or feed are scarce, the morbidity increases because of the immune system is very low at that particular point in time. But whenever the animals have enough feed, no concurrent infection, morbidity tends to be lower. And that is why sometimes even in the event of outbreak, you see half of the population may not show any clinical sign of infection while the outbreak is happening. Next slide. Yeah, the clinical signs can be divided into 4 forms: per acute, acute, subacute, and chronic forms. But in the field, it is difficult to differentiate between those four forms. The ones that are commonly being seen in the field are the acute and the chronic forms, although they interwoven and interlapse. For instance, in per acute, 10% of the infected heart, per acute, up to 10% of the infected heart, and it is characterized by sudden death, often without any clinical signs. For the acute form, about 20% of the affected cattle, and this is the most crucial form of it, where if this acute form is detected early based on the following clinical sign, intervention may yield fruits. For instance, the sudden rise in body temperature of up to 41, 42 degrees Celsius. The animal experiences severe depression and lingering behind, anorexia and cessation of rumination, respiratory distress, persistent cough, thoracic pain due to acute bronchopneumonia being an inflammatory disease, adopted elbow on standing, mucopurulent nasal discharges, sometimes with streaks of blood, arched back with head extended towards the wind direction because the animal is trying to aspire, trying to breathe because of the congestion of the airways, shallow and rapid respiration. Next slide. Yeah, this plate is showing the extended neck, showing the animal trying to get fresh air, and that is why it's turning towards the direction of the wind to get fresh air. And then other slide is the abducted forelimb. No, go back, previous slide. Yeah, abducted forelimb, and you can see the submandibular and dewlap edema. Next slide. Next slide. Yeah, pleuritic friction on auscultation and crackles and moist rails on auscultation. Later, through percussion, you have a dull sound area of the lungs, edema of the thorax and dewlap. Sometimes you may have bloat as indicated in the plates. And for calves, they will have polyarthritis. The bloat is not commonly seen in all cases. What is responsible for the bloat here, apart from the cessation of rumination, was as a result of the perceived or speculated to be as a result of the vagus nerve, which is the longest cranial nerve that traverses from the central nervous system through the thoracic cavity up to supply the visceral organs, particularly the rumen. So as the vagus nerve traverses through the thoracic cavity, the massive inflammatory processes going on tend to affect the vagus nerve. And when the vagus nerve is inflamed, the function of causing ruminal motility also is affected, and that leads to ruminal cessation, and then the animal becomes bloated. Next slide. Next. Yeah, the subacute form, about 40% to 50% of the affected cattle show the subacute form, and sometimes it resembles the acute form. And most of the times also, it's less severe and with recurrent fever. Difficult really sometimes to identify in the field, whether you are dealing with acute form or subacute form. For the chronic stage, it also overlaps, but one thing that is clear in the field when it becomes chronic is that the animal becomes so unthrifty, meaning is not putting weight and having chronic cough, sometimes with mild respiratory distress on exercise. So such an animal become a source of infection to others because they remain as carriers. Next slide. Next slide. Next.
Pathology, doctor.
Yeah, pathology. Yeah, pathology. During necropsy, lesions are confined to thoracic cavity and the lungs. Large quantities of clear, thick yellow-brown fluid containing fibrin, resembling an omelette, will be seen. The interlobal spaces, as indicated in the plates presented, tend to be distended with amber-colored fluid. Lung become consolidated, looking like a liver when a cross-section of it is being cut with marbled appearance. And the sequestrum of necrotic foci surrounded by fibrous capsule may be seen in chronic cases. Addition between pleural surfaces with the ribs are constant findings when the disease becomes so chronic. Next slide. Yeah, diagnosis of the disease. Heart history, clinical signs, necropsy findings, all together will lead to tentative diagnosis. Laboratory diagnosis, such as culture. If it is in a live animal, nasal swab and discharges from the nostril can be used as culture sample for cultures, as samples for culture. And at necropsy, the pleural fluid, disease lung, and lymph nodes are samples to take. Immunohistochemistry, real-time PCR can be useful, particularly in chronic cases. Next slide. Yeah, OIE recommended serological test for heart diagnosis, not individual diagnosis, and implementation of control plans. So based on this serological test, information can be gotten in terms of control plans. Complement physician test, because when you now use an individual animal, sometimes when the disease is becoming chronic, the animal may not really show positive response to complement physician test. But on the hard basis, control can be instituted. Competitive ELISA immunoglobulin test. Another important diagnostic tool also that is sometimes is not being utilized is participatory epidemiology. This is where the local farmers in the interlands, in difficult terrains, they are the people that are with this animal for many years. So they know the disease, and when you have a discussion with them round table in their villages, in their bushes, they will describe the disease, and sometimes they will even tell you what remedy they are using to ameliorate the pains. So when one is talking about control measures, when one is talking about identifying the disease, participatory epidemiology is very important, need not to be neglected. Differential diagnosis, pneumonic pasteurellosis is similar clinically and at PM, but during culture can differentiate the causative agents, Pasteurella, organism, and species, and then mycoplasma. They are quite different. Pulmonary abscesses and tuberculosis. Tuberculosis show granulomas, particularly at PM, and so cannot be confused with mycoplasma infection, which is CVP. Next slide. Yeah, these are, no. Yeah, treatment, prevention and control. There are 4 essential strategies, although not limited to this: vaccination, treatment, control of animal movements, and stamping out. All of these put together can lead to eradication of the disease or control. Treatment: antimicrobial usage in infected cattle tend to reduce the infection rate by 50%, mortality rate by 64%, and prevalence can also be reduced from 75% to 33%. The treatment here is targeted towards the circulating mycoplasma before they become sequestrated. And therefore, whenever an antibiotic that is potent is being introduced in form of treatment, it's not only targeting the mycoplasma. Even if there are other complicating secondary bacterial infection, meaning there is a concurrent infection going on, and that other secondary bacterial infection is susceptible to the antibiotic that is being used to treat CVP. At the end of the treatment, the body condition of the animal improves. And so the owner becomes so happy that the animal have now recovered, unknown to them that those that have recovered, a few of them may become carriers. So the essence of the treatment here is to improve body condition of the animal so that even if the farmer wants to sell, he will not incur much losses than when it is not treated. So that is the advantage of the treatment. It's not targeting, eliminating the mycoplasma completely from the animal, but those that are within peripheral circulation and concurrent infection going on. So definitely it tends to improve the body condition of the animal, and the animal looks apparently healthy. Next slide. Yeah. Some of the effective antibiotics include oxytetracycline, 20 milligram per kg body weight IM, to be repeated within 3 to 5 days. Tylosin at 10 milligram per kg body weight twice a day for 6 days. But each of these 2 antimicrobial, whether oxytetracycline or tylosin, if you're using oxytetracycline, the advantage of it is tend to give you, it tend to reduce the labor cost in terms of restraining the animal, because after giving 1 injection, you wait for 3 to 5 days before you repeat. Compared to tylosin, that you have to restrain the animal twice a day to inject for 6 consecutive days. It is cumbersome. If you don't have a good restraining facility, it is difficult. And if the veterinarian is coming from a far place into the hinterland to attend to the herd, you can see the cost of transportation. So each one of these has its own advantage and disadvantages. But there are other also antibiotics like fluoroquinolones, like danofloxacin, marbofloxacin, and the rest, including the macrolides like the tulartromycin. And in addition to the antimicrobial, you need to also combine with anti-inflammatory agents, either steroidal or non-steroidal, dexamethasone or diclofenac. All of these tend to reduce the pains as a result of the massive inflammatory processes going on. And then for the animal facing towards the direction of the wind, it shows that the nostrils are congested and therefore need to be open. So if you use nasal decongestant like nasal spray or nasal drops, it tends to open the airways and the animal gets relief. For the appetite stimulants like multivitamin, during the cessation of rumination, particularly in the acute stage, we all know that the B complex are being produced naturally in the rumen of cattle. So whenever there is problem with the rumen, cessation of rumination and the rest, those normal activities of the rumen by producing this B complex is being tampered with. And therefore, one need to boost the appetite of the animal, because anorexia, cessation of rumination, are the clinical sign you see during the acute stage. And therefore, your treatment is not only targeting the organism, but you are also ameliorating the clinical signs using those agents. Next slide.
Yeah.
Next slide.
Where is vaccination? Yeah.
Next slide.
Yeah.
Yeah. No.
Vaccinations.
Vaccination. Vaccination.
Yes.
OIE recommended attenuated vaccine, the T144, which is widely used. And some countries are using T1 streptomycin strain type. The problem with vaccination, there are a lot of constraints or activities or certain practices that sometimes render vaccination not really good enough. Number one, cold chain. If the vaccine, being a live vaccine, if it is not kept in a good cold chain, it loses its potency. Number two, over-dilution of the vaccine. The one that is shown in the on the slide is being produced in Nigeria by the National Veterinary Research Institute. It comes as a 50, in one vial goes for 50 animals, meaning when you dilute it, you give 0.5 for each cattle. But some, I don't want to say, previous slides.
I think we lost connection with professor again.
Yeah.
I hope he will, will join. Yeah, he has joined. Yes, professor. Is this the slide you were wanting me?
Yeah, next slide.
Vaccination slide, right? Professor, is this the one?
Yeah, I was.
Vaccination slide, right?
Yes.
Right. Yeah, okay.
Yeah, I was talking about the challenges that are being faced in the field when it comes to vaccination. So, and I talked about the cold chain, maintaining cold chain for the vaccine, being a live vaccine. I also was talking about the dilution factor. The vaccine need to be diluted in the diluent. The one that is showing on the slide, I said it is meant for 50 animals. So you dilute one vial to 50 mils of normal saline. So if there are certain practices that veterinarians or quacks, let me put it that way, they dilute it in 100 mils instead of 50 mils so that they can now dispense one mil. So in that situation, the vaccine is over-diluted. And for immunogenic effect to take place, the particular quantity that is being injected into the animal has to at least have minimum 107 colony forming units. And so if it is not up to, it will not stimulate the needed antigenic effect. So these are some of the challenges. And the AU IBAR recommended policy is that for epidemiological data, and information collection. Active surveillance has to be instituted, identify foci of CVP occurrences, regular annual mass vaccination of cattle herds, at least uh, two intervals in a year for at least 5 consecutive years, with attainment of a herd immunity and an effective movement of cattle to be controlled from the infected foci away from the infected foci to where it is safe. So these are policies that tend to control the disease. But for the sake of time and the network that is, becoming erratic, particularly on my side here, I will stop here. If there are questions, there are contributions and comments, I'll be willing to take. And next slide. Next slide. Yeah, thank you.
There are one question.
So, Professor, there are some questions being floated here. I'll post them now. So, if you could answer those questions, it would be of great help to the participants.
Yeah, these are some of the references that I've used, which is verifiable.
Let's see.
Yeah, references are here. So I'll pose the questions to you now. So there is one anonymous attendee who don't want to expose his name, has asked that why do we use anti-inflammatory, which is a steroid, dexamethasone, instead of using NSAID? So what is the purpose of using dexamethasone? What is the logic behind? So, Professor, am I audible now? Professor, could you hear me?
Yeah, I can hear you.
Yes. So there are some questions being floated from our valuable attendees. So there is one question from Anonymous who has not exposed his name. So the question is, anti-inflammatory, why we use dexamethasone, which is steroid? So he's asking what is the logic behind using a steroid rather than NSAID as an anti-inflammatory for this disease? Doctor, am I audible? Doctor?
Can you hear me?
Yes, I could hear you. Would you able to hear me?
Can you hear me?
Yes, yes.
Hello?
Yes, Professor.
Hello?
Yes.
Hello?
So, हाँ? नहीं, मैं ये क्या पहले इसको प्रोफेसर को आंसर करना.
Hello?
Professor, would you able to hear me? इतना देर से सुन रहा था, ये क्यों नहीं आ रहा?
Hello?
Would you able to hear me, Professor?
I had the part of the question that said somebody was asking about dexamethasone.
Yes.
Why
yes.
the use of dexamethasone being a steroid instead
Yes.
of non-steroidal?
Yes, yes.
Right?
Yes, exactly.
Yes, this is what I had. So let me respond to this. Yeah, why the choice of non-steroidal it's not as if non-steroidal cannot be used. Here you're using antibiotic consecutively if you're using tylosin consecutively. Or if you are not using tylosin, you're using the oxytetracycline long-acting. That effect of the dexamethasone that normally increases vulnerability to infection, the antibiotic will take care of that, will handle that aspect. But in addition to this, the dexamethasone tend to dilate the blood vessels, apart from uh, relieving the pain, suppressing the, say, non-steroidal anti-inflammatory like diclofenac cannot be used. I mentioned it in my presentation that either of these can be used. But one thing that is so common that farmers and clinicians or veterinarians normally use is that the dexamethasone that is available, and it comes in a quantity that you can easily pick as an animal product and use, compared to non-steroidal that is not really available in the market. But either of these can be used, particularly if you have a non-steroidal, you can use it. But where you have the dexamethasone, since you are using, you have antibiotics, you can use vulnerability, subjecting the animal to vulnerability to further infection. That is not really the case as we have been observing in the field. So thank you.
So we have another question from Mr. Usama Salah. What is your antibiotic of choice for the treatment of contagious bovine pleuropneumonia? What is the antibiotic of choice for this disease, CBPP? Is posted by Mr. Usama Salah.
The antibiotic of choice is the antibiotic of choice.
Yes.
Right?
Yes.
Yeah, the antibiotic of choice based on, it depends on region to region and individual practitioner. But the one that is so common in the field that we've been using and it's giving result. The tyrosine used to be good, but people have abused the use of tyrosine and the cumbersomeness of injecting the animal twice in a day for 6 consecutive days. Farmers, including veterinarians, tend to shy away from this cumbersome nature of using it. And therefore, majority around this part of the continent use oxytetracycline long-acting because of the fact that once you inject, you wait till 3 to 5 days before you inject. Even at there are an extra level use of oxytetracycline long-acting that is also being observed in the field to be yielding results. What is that extra level use of oxytetracycline? What we have observed is that when you calculate the total dose of the oxytetracycline to be administered to a particular cow, you divide the dose into 2. You administer half of the dose intramuscular and half of the dose slow IV. This is an extra level use of oxytetracycline. What is now remaining is for one to go into research to see what is the implication, because it tends to really produce good results. But no research is ongoing to really establish the adverse effect of it when such is being administered. But I tell you, it's giving result in the field. It's an extra level use of it. So companies need to research into it to find out, is there any way we can produce oxytetracycline that can be administered IV and at the same time IM? Because this is what we have observed in the field. So, and others that are being used, which we are monitoring, is the use of these quinolones. So the use of quinolones, some people are still trying it. I can't say authoritatively how effective it is for now. We are still monitoring. Thank you.
Thank you, doctor. Thank you, professor, for this excellent answer. And I hope Mr. Usama's query has been answered. So there is another question from Mr. Michel Dauda. He has asked, thank you for the insightful presentation, sir. Please, at what stage do you carry out stomping out?
This is one of the problems that control or eradication of contagious bovine pleuropneumonia, particularly on the African continent. You cannot do stamping out. Stamping out, once the disease is confirmed, the entire herd need to be quarantined and stamped out, and then farmers will now be compensated. But where you don't have political will, money cannot flow. No any farmer will allow anybody, at least, to stamp out the entire herd or even a few of them without compensation. So this is one of the major challenges. So if there is money and there is a political will, once there is detection of the disease in that particular herd, so stamping out combination of stamping out, particularly if the borders are not porous, stamping out can be effective in eradicating the disease. But if the borders are porous, even if there's money and political will, it will not work. The disease also need to be in place. So stamping out involves a lot of things that has to be put together before it can be effective. Most African countries have land borders. It's not like the UK, which is an island that you can easily control what is coming in and what is going out. So thank you.
Thank you so much, Professor. There is another question from Comrade Daffel, Nigeria, Gombe State. Professor Dunbirni, thank you for this wonderful presentation. Keep it up. Please, I want to know if there is home remedy when the animal shows all the signs before taking the animal to clinic. So he wants to know, is there any home remedy available before he could take the animal to clinic?
Well, to the best of my knowledge, I don't know any home remedy. The best thing that a farmer will do that will not make you to lose the animal or even have an economic challenge is for you to patronize your veterinarian, because veterinarians in Nigeria, they are not scarce. Almost every local government, you will see veterinarians. There are clinics, veterinary clinics. So instead of resorting to home remedy, it's better we use what has been proven by companies and researchers. That way, you are sure of an effective use of such product to solve your problem. And the animal will not suffer on account of trial and error of home remedy. So thank you so much.
Thank you, Doctor. Thank you, Professor. There is another question from David, Dan, and Daisy. Kindly give more explanation on the dilution of vaccine. One is supposed to administer 0.5 ml, but it seems you said 1 ml. Dr. DD and Easy. So he's asking about vaccine dilution. What is the exact amount? What is the exact dose which is supposed to be administered? He says the supposed volume is 0.5 ml, but in your presentation, you might have said 1 ml. So he is a bit confused. What is the exact dose that is to be administered?
Okay, the vaccine that is being produced in Nigeria by the National Veterinary Research Institute for the control or prevention of contagious bovine pleuropneumonia is 1 vial. It comes in 1 vial, and you dilute it in 15 mils of normal saline. And that 15 mils, you administer half a mil, that is 0.5 mils, to each cattle. That way, at least minimum 107 color. Some people that they may not be able to have a syringe that would dispense, or they don't have the patience of dispensing 0.5 mil for each cattle subcutaneously. Instead, they will now double the dilution, and they will be administering 1 mil instead of 0.5. So that way you have over-diluted the vaccine. And the tendency is that the 107 minimum colony forming units of the antigen may not likely be in the 1 mil you are administering. So you are just administering normal saline to the animal. So that way it may not generate the immunogenic effects that is expected of the vaccine. That is where the problem is, apart from the cold chain challenges that we are facing. Thank you.
Thank you, Professor. And there is another question from Gloria Caraye. Seems to be from University of Jos. My question is that since we have lungers or recovered carriers, why don't you advise more on stamping out, or when is the herd declared free of the disease? So the question seems to be if the animal seems to be chronic, or if the animal seems to be a carrier of Mycoplasma mycoides, why the farmer is not advised to stamp out the affected animal.
Okay, thank you. Dr. Karae from University of Jos. Why I will not recommend stamping out in the current situation we are having is the fact that if the farmer is not being compensated, it is difficult for any farmer to allow you to stamp out his animal. That's one. Secondly, there should be a diagnostic tool that will be able to discriminate those apparently healthy animals that are carriers. If there is no diagnostic tool that is available that you can easily detect those carriers, it is difficult for you now to begin to pick out the animals that are carriers. Even if you are able to pick a few clinically, and you have 1 or 2 in the heart that are not being picked, those ones will also remain as a source of infection to the entire heart. So it's like you've not done anything. You are coming back to one spot. So that is why stamping out has to be with the government political will, resources, and veterinarians or experts have to come together to really exhibit this or implement this policy of stamping out. It's not just stamping out. Farmers have to be compensated because farmers are keeping this animal for profits. So you can't just, no any farmer will just begin to stamp out his animal if he knows that he's going to lose. So thank you.
Thank you, Professor. There is another question from Dr. Abubakar Haruna. Thank you for the presentation, sir. Using dexamethasone for pregnant or lactating cattle can have issues. I suggest using a drug known as bioanazine C, which work out. Can I continue using it? For oxytetracycline from survey, the herdmen find oxytetracycline as a common drug, which in most cases there is resistance. So his question is highlighted in two points, I could say. One is using dexamethasone on pregnant cattle. And he is suggesting something called, where is that one? Bioanazine C. What is that one? The first part of his question is using dexamethasone in pregnant and lactating cattle. His question is that
I didn't
Professor Dr. Abubakar Haruma, he is asking that using dexamethasone for pregnant or lactating cattle can have issues. Instead, he is suggesting to use a drug known as bioanazine C. He is asking, can he continue using it?
Well, if it is giving him results, he has to continue. But I don't know much about the drug he was suggesting or anti-inflammatory agent he's suggesting. I don't know much about it. But if it is giving him results, we need to find a way of verifying it to see whether it can replace the dexamethasone that are widely being used. There's no harm in sharing that your experience with other veterinarians in a forum like this so that it can be verified in the field when proven to be effective without any side effects. Then it can be publicized for many veterinarians to be using. But for now, I don't have verifiable facts that I can recommend what you are using to many farmers. Thank you.
And Dr. Abubakar Haruna has asked another question. Oxytetracycline, though being a common drug, but he is finding it that there is a resistance for this drug. For oxytetracycline, he is
which
doubtful
drug?
that there might be a drug resistance for oxytetracycline.
Okay. He said there may be resistance.
Yeah.
There may be resistance to the use of tetracycline long-acting.
Yeah.
The cases of drug resistance is not only limited to tetracycline alone. Particularly in Nigeria, the mostly abused antibiotic in animals when it comes to the treatment of contagious bovine pleuropneumonia is the tylosin, not oxytetracycline. Because tetracycline, even to professionals, even to veterinarians, even to paravets, if you are not really committed, if the farmer is not willing to take the bill of your coming daily, twice in a day to inject his cattle, to restrain and inject, it is bound to be abused. And that has been the trend over the years. And so the antibiotic that came to the rescue is the oxytetracycline. And the resistance that is being perceived, we need to conduct an extensive study to establish that assertion. Otherwise, we will do with what is available. And thank God that microclonons are now in the market. They are being monitored in the field. Possibly if they are
We lost Professor's connectivity, it seems. To add a point on to oxytetracycline usage, even FAO suggests that oxytetracycline is the most effective drug for controlling or treating contagious bovine pleuropneumonia. Using oxytetracycline has got almost 80% recovery rate. Even with the lung score, it seems to have excellent lung recovery score while using oxytetracycline. So Professor has joined again. So I allow Professor to continue.
I didn't get you. I didn't understand the question. Is it a question or a comment?
No, Professor. Since your network was lost, I was just adding some point to what you've been answering regards to oxytetracycline usage. So I believe it has been answered. So let's move on to next question from Ziaul Haq Haruna. Sir, I need more explanation on reconstitution of NVRI CBPP vaccine. I think, Professor, you have answered this question previously to another attendee's query, I believe. Could you hear me, Professor? Professor? Dear Mr. Ziaul Haq Haruna, Professor has answered this question. So one of our another. So Professor.
No, I didn't hear you. Can you summarize?
Yeah. So regards to Ziaul Haq, there is another question from Mr. Ziaul Haq. He's asking he need more explanation on vaccine
My network
reconstitution.
went off. Can you?
Yeah. Mr. Ziaul Haq wants to know more on reconstitution of NVRI
More
CBPP
explanation
vaccine.
on what?
Could you hear me? Could you hear me, Professor? Could you able to hear me, Professor? Are you hearing me? Are you with me?
More explanation on what? I didn't get it.
So let me move on to next question.
I didn't hear you.
How about now? Am I audible now?
Yes, yes.
Yeah. So Ziaul Haq Haruna has asked he need more explanation on reconstitution of NVRI CBPP vaccine. I think you have answered this question previously.
Yes, yes.
So let's move on to next question from Dr. Abubakar Haruna again. So stamping out will be difficult in rural area. How best did you think it be carried out? Again, this question was also answered previously.
Yes, sir. Yes.
So I believe let's move on to next question from Stella Chalo. How can we differentiate traumatic pericarditis and contagious bovine pleuropneumonia in a clinical presentation, especially for the people who are in the field where there is no laboratories? So they need a differential diagnosis between traumatic pericarditis and contagious bovine pleuropneumonia.
The based on field diagnosis, based on clinical science, it is difficult for one to really identify a case of traumatic pericarditis because this is a situation whereby the animal has taken a hardware, whether a nail or any object that pierces the reticulum and affects the pericardium of the heart, causing massive inflammatory reactions. And it takes time. And the animal doesn't respond to any drug, whether antibiotic or any other antimicrobial. When you see such case, apart from the animal becoming so resistant to movements, the animal become anorexic, and any attempt to exercise the animal resists. This is what is similar in acute form of contagious bovine pleuropneumonia. And that is why you want it differentiated. So for the case of traumatic pericarditis, the animal doesn't respond to any form of antibiotic because it is an hardware disease. The only way to be sure of your diagnosis is to conduct an X-ray. An X-ray will reveal the piercing objects. But you said in a rural area. So in a rural area, you can find an X-ray. So whenever there is a case of CBP, a case of CBP does not affect only one animal. Before you could see the sign in one animal, other animals might have been infected also, being an infectious and contagious disease. But in the case of traumatic pericarditis, it is an individual case. So this way you will be able to differentiate whether you are dealing with an infectious agent that is affecting more than one animal, or you are dealing with a case that is affecting only one animal. That way, that will give you a clue, in addition to other clinical signs of contagious bovine pleuropneumonia that I have previously explained. In traumatic pericarditis, those clinical signs are not there. So thank you.
Thank you. Thank you, Professor. And there is another question from Dr. Samaila Dawab Silvanos. If a pregnant cow in her first or second trimester is diagnosed with acute contagious bovine pleuropneumonia, what best treatment should be given, considering the effects of oxytetracycline on fetus?
You have to look at it, the prognosis. If you look at the acute form of contagious bovine pleuropneumonia, there is sudden rise in temperature, high fever. That high fever alone is enough for the cow to throw away the pregnancy. But where you have to weigh whether to not use the tetracycline to save the animal, even though she may abort the pregnancy, or not really abort, because we are talking about the effect, the tetragenic effect of the tetracycline on the pregnancy, the fetus. So other antibiotics can be used, like these quinolones that I have mentioned about, can be tried. Above all, you can also try the tylosin, although widely abused, but the quinolones can also assist to avoid the tetragenic effect of the tetracycline. Thank you.
Yes, thank you, Professor. There is another question from Michelle Dauda. Dexamethasone is thought to increase tissue perfusion of antibiotics using contagious bovine pleuropneumonia treatment. How true is this, sir?
Take it again.
Dexamethasone is thought to increase the tissue perfusion of antibiotics during CBPP treatment. How true is this?
Okay. We are not only, well, that can be verified in the literature, but we are talking about clinical experience here. Apart from the suppression of the inflammatory processes, and which is the major thing that we are targeting by the use of dexamethasone. Once you administer dexamethasone IV and it's widely available, along with the tetracycline, you achieve an appreciable result the following day. It is that effective. So, but if we want to probe whether part of the role of dexamethasone is to increase or dilate or increase perfusion, that can be investigated further. Thank you.
Thank you so much, Professor. There is another question from Abraham Ayuba Kabini. Can I vaccinate other animals that didn't show clinical signs of the disease in the herd?
You don't vaccinate sick animals. Sick animals are not to be vaccinated. Moreover, you are dealing with a live attenuated vaccine. But the general rule is that any animal that is sick, regardless of the disease, you don't vaccinate. Thank you.
So there is another question from Jeremiah Simon. Please, Professor, sir, you said the dilution factor is 1:100. It is termed as over dilution. How do we get about administering the vaccine if the calibration of our automatic vaccinator is 1 ml and not 0.5 ml? He is asking about his own limitations. If his automatic vaccinator is having a calibration of 1 ml and the dose is 0.5 ml, how could he able to vaccinate 0.5 ml with the dosage with the doser which is calibrated as 1 ml? Let him buy and you.
Thank you.
Professor, are you with us?
Can you take it again? I didn't hear the question.
Yeah, just go back. Yeah. The question is from Jeremiah Simon. He's asking, you said the dilution factor
Yes.
is 1:100. It is termed as over dilution. How do we get about administering the vaccine if the calibration of our automatic vaccinator is 1 ml and not 0.5 ml?
Well, the dilution of the vaccine, you have to get it right. When you are dealing with a precious animal, when you are dealing with something that is bringing you livelihood, you don't take shortcuts. You have to find a syringe, whether automatic or the normal syringe, such that you will be able to dispense what is recommended. There is no shortcut to it. Shortcuts are the things that is really causing problem in the eradication of the disease. Let's do the right thing and attend towards making the standards the best practice. Thank you.
Thank you, Professor. There is another question, Saminu Christopher Kauja, about timing the vaccine. Is it before, during, or after treatment?
Okay. Whenever there is an outbreak, the best thing to do, or the general rule, whether there is an outbreak or not, you don't vaccinate sick animals. That should be our standard all the time. So whenever there is an outbreak and you are able to distinguish between those that needed to be treated and those that are not really infected, but they may be incubating the disease. If you now begin to segregate and say, these ones are the affected, these ones are not affected, unless if you are using a diagnostic tool that will be able to segregate such. Otherwise, the ones that looks apparently healthy within the same heart at the face of an ongoing outbreak, they may be incubating the disease. So the best thing is for you to treat all of them and then wait for a certain period, let's say 3 weeks or thereabout. By that time, the antibiotic effect might have wear out, and then you now check the temperatures of the animal. If there is no any sign of fever, then it is assumed that you are likely to achieve tangible result when you vaccinate the herd. Thank you.
So there is another question from Rafael Lucas. What is the recommended site of vaccine administration?
I didn't get it.
What is the recommended site of vaccine administration? The question was posted by Rafael Lucas.
Okay. The site of CBP vaccine is subcutaneously administered. And veterinarians know the site to use. Farmers need to liaise with their veterinarians so as to inject. We always discourage farmers from administering the vaccine on their animals. And therefore, if the person that is asking this question is a veterinarian, he might have passed through anatomy, he might have done his internship. So this is not a forum where we begin to teach others that are not veterinarians on how to vaccinate cattle. That will result into quackery, and that is what is really not helping us in terms of eradication of certain diseases. So if the person asking the question is not a veterinarian, I advise that he liaise with his veterinary doctor, and every veterinary doctor knows the site where to inject. It's not that I don't know, but I know. I'm trying to maintain standards.
Yes.
Thank you.
Yes. Excellent answer from Professor. Being an academician, this is what I, being a veterinarian, expected from you. So, so there is another question from Mr. Abhijit Chattopadhyay. Meloxicam is safer in pregnant and lactating cows. So he is recommending instead of dexamethasone, why can't we use meloxicam when it is safer in pregnant and lactating cows?
Can you summarize the question? I didn't get it.
Mr. Abhijit Chattopadhyay, he is saying meloxicam is safer in pregnant and lactating cows. Can we use this one instead of dexamethasone? Professor, the question is, meloxicam is safer in pregnant and lactating cows. Can we use this one instead of dexamethasone, at least in pregnant and lactating cows? Professor, would you able to hear us? Are you hearing me? Could you hear me? Could you hear me, Professor? Hello. Professor, would you able to hear me? Are you with me? Professor, would you able to hear me now? Could you hear me now? Professor, would you able to hear me now? Are you hearing? Are you with us? Professor?
Hello?
Yeah, could you hear me now?
Yes, the network went off. I can hear you.
Yes. So Mr. Abhijit Chattopadhyay is asking, meloxicam is safer in pregnant and lactating cows. Professor? Professor, could you hear me now? Professor, could you hear me now? Are you with me? So Mr. Abhijit is saying meloxicam is safer in pregnant and lactating cows. Can we use this meloxicam instead of dexamethasone in pregnant and lactating cows? Professor, could you hear me? I think we have lost connectivity with Professor. So so let me try to answer this question. So meloxicam is always safer.
I didn't get you. I didn't hear you.
Could you hear me now? Could you hear me now? So I think we lost connection again from our professor. So yeah, it is always safer to use meloxicam in pregnant and lactating cows when especially when you are having a temperature of 40 to 42 degrees Celsius in acute cases. Meloxicam is the safest drug, and meloxicam can be given as a single shot. So if you are using a real meloxicam from a good supply, good manufacturer, so one single shot of meloxicam is enough. So Professor, could you hear me now? Professor? So we have just two
Okay,
more questions.
I am back online, but
Yeah,
I didn't hear you. Are you contributing or is another question?
yeah, could you hear me now? Could you hear me now?
Yes,
So we'll be very more than
I
happy
can
to
hear
get the
you,
answer
but
from
it's
your part.
cutting.
So there is Mr. Abhijit. He is saying meloxicam is safer in pregnant and lactating cows. I think again we have lost connection from Professor. What is the recommended route of vaccine administration? Professor has already answered this question. So again, Dr. Samaila Dawab Silvanus, do you advise vaccination or treatment of an entire herd where 2 or 3 herd members were diagnosed with the CVPP? Again, Professor has answered. So again, Professor is back with us. Professor, could you hear me now?
Yes.
So Mr. Abhijit has asked meloxicam is safer in pregnant and lactating cows.
Which drug?
Meloxicam, meloxicam.
Meloxicam.
Yeah.
Whether it is safer in pregnant cows?
Yes, pregnant and lactating cows.
Well, I have not been using that. I may not authoritatively say so. If he has tried that and it has been working for him, he can discuss with fellow veterinarians like us so that we'll be able to understand and also venture into using it, particularly in conferences and in workshops, that he can share this knowledge with us. Thank you.
Right. And there is another question from Dr. Samaila. Sir, do you advise vaccination or treatment of an entire herd where 2 or 3 herd members were diagnosed with CVPP? Thank you, sir.
Treatment with which animals?
No, Dr. Samaila is asking, do you advise vaccination or treatment of an entire herd wherein only 2 or 3 herd members were diagnosed with CVPP?
Well, if the consulting veterinarian have taken the pains to arrive at a diagnosis in the farm, I think he can as well also be able to differentiate those that are incubating the disease and those that are diseased. If he is able to differentiate that, then he can do selective treatment. But if he will not be able to differentiate between those that are apparently healthy, yet they are incubating the disease, from those that are already showing clinical signs, if he is able to do that, then he should do discriminatory treatment. Otherwise, the safest thing to do under field condition, in order not to have a relapse or to have, you will treat today, after 2 or 3 days, those that were not treated but incubating the disease begin to show clinical signs. That will not really put you in good light as a veterinarian. The farmer will not even be happy. So the best thing, the best approach is for you now, since you can differentiate those that are incubating the disease, which look apparently healthy, and those that are already showing clinical signs. The best thing is to do total herd treatment. That is safer for you and the farmer. Thank you.
So I think we are at the end of this question section. So there is just one more question, Doctor. Professor, is there any reported cases in water buffalo? The question is posted by Abdul Maliki Hamis.
Well, according to literature, there are reported cases of CBP. I'm not much sure. I will check later in South Africa. But in Nigeria, I have not come across any reports of CBP in water buffaloes.
And also,
but that is not to say that we may not really find in other countries. We can search for it and see, particularly under the OIE or FAO website, and see whether there are of recent reports indicating that. Thank you.
so same Mr. Abdul Maliki is questioned that what is the recommended age for vaccination? What is the recommended age for vaccination?
The
Recommended age for vaccination.
recommended years for vaccination. It depends on the breeds that you have, the breed of the animal. But one thing that is a guiding principle is that you make sure the immune system of the animal you're vaccinating is well developed and there's no concurrent infection that might have lowered the immune system of the animal. But because you're talking about at what age, meaning the younger ones, the calf. So most of the time is from 6 months and above, depending on the breeds that you have. It is assumed within that 6 months or before that 6 months, the immune system of the animal might have developed well to be able to generate antibodies when an antigen is being injected. 6 months, most of the time is recommended, depending on the breeds. But the key principle is considering the development of the immune system of that calf. Because
I think we are no. Professor, yeah, thank you so much for your answer. And there is another question. Can we use normal CBPP vaccine for buffalo? Can we use CBPP vaccine in a buffalo herd? So there is another question. Can we use CBPP vaccine in a buffalo herd?
Well, I don't know for now. I don't know for now. I've never used it. I've never seen a buffalo that was infected with CVP, but I've read. Therefore, I don't have the authority to make that assertion that it can be used. The one that is being produced by the National Veterinary Research Institute here in Nigeria is recommended for cattle. I don't know whether other countries have a vaccine for CVP in buffaloes. That needs to be investigated.
Right. Thank you. And there is another, just one more question. Osama Salah has asked, is CBPP a zoonotic disease? Professor, are you with us? I think we lost Professor.
But things are changing. But for now, it's not a zoonotic disease to the best of my knowledge. Thank you.
Thank you so much, Professor. I think we are at the end of this question and answer session. And I thank you personally for all your patience and answering all the questions. with a deep insights rather than just answering in one single word. So I thank you very much on behalf of Ashish Life Sciences. So we are at the end of on the final part of this webinar, wherein we have a spinner wheel to select 3 lucky winners. So shall we go into it? So please, let's go for this lucky winner selection. Let's go into this spin the wheel session. Yeah. Yes. So
Yeah.
spin it. Yes, go ahead and spin it. So our first lucky winner is Mr. Rayanu Usman Adamu. So one of our Ashish Life Sciences executive staff would be reaching out to you. So let's go for second spin to select the second winner. Dr. Arif, no? Yeah, Mr. Saidu Muhammad Baude. So he is our second lucky person. So one of our Ashish Life Sciences staff would be reaching out to you. So let's go for third winner. Let's see who is our lucky person. Sophia Sani. So one of our Ashish Life Sciences person would be reaching out to you. So I thank everyone on behalf of Ashish Life Sciences to have attended this meaningful and knowledge sharing webinar on contagious bovine pleuropneumonia. And I thank Professor for all his patience and his contribution. Despite a lot of hardships and a lot of shortcomings, he has agreed to present this webinar. And we have successfully presented also. I wholeheartedly thank Professor once again and all our attendees. So let's meet with yet another knowledge sharing webinar. Hope to see you soon. Thank you all. Thank you so much. Thank you, Professor.
Thank you.
So shall we leave now?
Yeah.
Thank you, Professor. We can leave now.